Yep, hi. I'm Gabriel again here, and this time I'm going to give a little presentation on migraine. The last time we were talking about dysphagia. Migraine, of course, is has headache is one of the causes of a headache, and with regard to that, I'll actually make a PowerPoint presentation about an approach to headache, because headache is one of the common things seen in primary care, and we should know something about it. Here is one of the specific conditions which accounts for a significant proportion of headache that I believe we need to know something about. Alright, here goes. I have a lecture outline here. First, I'll introduce something about what's migraine and why are we even studying about it. So we need to know about the disease burden in Singapore, which I'll talk about. Following that, I'll define what migraine is. And also there are three subtypes of migraine which we will talk about in more detail. This is going to be a bit long and draggy because definitions are very important for migraine because it's a very specific clinical diagnosis from the history. Etiology and pathogenesis. We need to know something about the pathogenesis of migraine because the pathogenesis will teach us what targets we use and what drugs we can use to target the migraine. Some words in epidemiology then. A differential diagnosis, I'll offer a brief one here, but think more about it in terms of the context of an approach to a headache, an approach to an acute recurrent headache, which I will speak more about in my approach to headache. Subsequently, I'll talk about clinical features of migraine, and then I'll finish off with investigations and management. Hopefully the summary that I put up will be useful. Alright, without further ado, let me talk about why we're doing this topic. The impact of migraine in general is quite large. As you can see, according to the Singapore Headache Society, 10% of the Singapore population above the age of 12 have migraines. And migraine is actually a neurobiological disease. It's not just a headache. Therefore, it can actually cause significant morbidity in terms of neurologic problems. What I didn't write is also it causes significant functional impairment because migraine attacks typically last anything up to about 72 to 72 hours. Actually, usually the auras last less than 1 hour, but the pain actually can last anything up to 72 hours. So, they can have significant downtime. In primary care, of course, migraines are really common. As you can see here, 90% of the headaches seen in primary care do not have an organic pathology. That is their primary. And of these primary headaches, migraine is a major cause. The other really common one will be a tension type headache, which I will cover more in the approach to headache. Secondary headaches are actually quite rare in primary care, 10%. Of course, it's important to pick them up, and I will talk more about it in my approach to headache lecture. Therefore, it's important to know migraine because it's commonly seen and has potentially serious effects, affects the quality of life, and is treatable. Before we delve into the work proper, we need to know that headache is a symptom, whilst migraine, tension type headache, cluster headache, rebound headache, and any other chim words we can use actually diagnosis rather than actually being symptoms. So what this means is that for these things there are specific diagnostic criteria, which later we will see. The International Headache Society has come up with one of the diagnostic criteria kind of list, which is what brings me to definitions. Definitions are very, very important in all primary headaches. In particular, in this case for migraine, because the definition will actually give us an idea of the clinical features that are present in each of these. So I will define what is the migraine in general first, followed by each of the three major subtypes of migraine: migraine with aura, migraine without aura, and migraine variants. So what's the definition of migraine? It is blah 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 blah. What a mouthful. This is after the International Headache Society classification, which is published in Capitalogia in 1988. Put simply, migraine is a primary neurobiologic disorder which has clinical manifestations of recurrent attacks of unilateral throbbing headache lasting 4 to 72 hours. In most cases, if it lasts like 1 week, then you can call it a persistent migraine. Prolonged migraine is when it lasts more than 1 day. Okay, and there are associated symptoms, usually of nausea and vomiting, and oversensitivity to some sensory stimuli, like maybe light, sound, and touch. So, respectively, oversensitivity to sensory to light will be photophobia, sound is phonophobia, touch will be allodynia. Okay. Now, definition of the three subtypes of migraine. There are three main subtypes of migraine: migraine with aura, migraine without aura, and migraine variants. Migraine with aura is known as classical migraine. Migraine without aura is known as common migraine. And it's actually known as common migraine because actually 90% of migraineurs do not have aura. Migraine variants, these will be considered in more detail in the slide. So what's the definition of migraine with aura? It's blah 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 again. So I put it simply, rearranging it for you guys. It's a recurrent disorder with reversible focal neurologic symptoms. That is the aura. As you can see here, I've defined what aura is. So aura is the reversible focal neurologic symptoms, lasting usually over 5 to 20 minutes, but most of the time less than 1 hour, with a headache following the aura. Why did I put less than 1 hour for the definition of migraine with aura? Because it's actually very important to note the time that the person has the aura for. Because auras longer than 1 hour, red flag, can be quite serious. When you have aura longer than 1 hour with evidence of infarction or neuroimaging, this is a migrainous infarction. That means the migraine could have caused a stroke. Prolonged auras and persistent auras depends. So whether it's more than so prolonged is more than 1 hour, less than 1 week. Persistent is more than 1 week. But note here, both don't have evidence of infarction. Okay, the most common kind of migraine, migraine without aura, otherwise known as common migraine. Again, long definition. I put it simply, it's a recurrent headache with a typical typical characteristics. That means it's a migrainous kind of headache. And what are these migrainous headaches? They have unilateral location, pulsating quality, moderate to severe intensity, and are aggravated by activity. Note that there is no aura in migraine without aura, obviously, so there are no preceding focal neurologic symptoms. And migraine with aura is associated with nausea, photophobia, and phonophobia. So what are certain migraine variants? Note that all migraine variants are rather rare, okay? So here I've put it up. You guys can just have a look. Basically, retinal migraine, ophthalmoplegic migraine, and hemiplegic migraine. Quite chim if you see, like, it's a mouthful of words, really, okay? So here, put simply, retinal migraine is when you have monocular visual disturbance with migraine headache. The visual disturbance can be maybe a scotoma, which is a blind spot, or complete blindness in one eye. Ophthalmoplegic migraine is when you have ocular cranial nerve paralysis with a migraine headache. And hemiplegic migraine is when you have unilateral motor or sensory symptoms with a migraine headache. Hemiplegic migraine can be further divided into sporadic or familial forms. So it can be sporadic hemiplegic migraine or familial hemiplegic migraine, depending on whether one has relatives affected by it or not. Alright, I have to stop here because 10 minutes is